Good evening, everyone. I'm Joan Winsenson. I'm the director of Conquer Myasthenia Gravis, and welcome to this evening's webinar, Emerging Therapies for MG. We'd like to thank our sponsors, and I'm going to pause. Oh, there we go. I needed to see the, thanks. I needed to see the slides myself as well. We'd like to thank our sponsors tonight. They include argenx, Alexion, AstraZeneca Rare Disease, the Janssen Pharmaceutical Companies of Johnson & Johnson, and UCB. We're very grateful for their support. I'd like you to keep in mind that each person's experience is unique, and this webinar is not a substitute for medical advice. Our presenter today is Dr. Pritikanta Paul. He's a neurologist associated with the University of Illinois at Chicago and UI Health. Good evening, Dr. Paul.
Good evening, Joan. I'm glad to be here today.
Great, me too. Before you start your presentation, I'd like to share some responses that we received in advance from our audience. We asked people how long they've had myasthenia, and a sizable number, 13%, said just a year or less, while over a third said that they've had it from between 2 to 5 years. And then nearly half have had myasthenia longer than that, more than 5 years. So it's a good representation of people with different levels of experience with the illness. We also asked when was the last time they had a conversation with their doctor about medical treatment options. And the good news is that most of the people that responded, it's been within the past year. So over 80% have had conversations with their doctor recently about treatment options. Today, Dr. Paul is going to talk to us about emerging therapies for MG, something that you might want to discuss with your doctor in the near future. His presentation is about 40 minutes. I want you to know also that there will be time for questions. If you could take a minute to look at your screen and look at the lower left-hand box, there is a box labeled questions. And so if you could, I saw that a number of people have already typed something in, but if you could type in your name and maybe where you're from just to get used to that, feel free to do that. Okay, that's it. Go ahead, Dr. Paul.
Thank you, John, so much for the introduction. Good evening, everybody. I'm really glad to be here for this presentation. And I just wanted to highlight again one thing which Joan mentioned. Myasthenia gravis is a unique disease in which patients' symptoms, severity, and the presentation varies from individual. And we as physicians always try to individualize treatment for the maximum of the optimum benefit. So today's presentation is just to give more general awareness about the emerging treatment options in patients with myasthenia gravis. This is just to kind of familiarize ourselves with some of the terms I might be using during the presentation, particularly with acetylcholine receptor, acetylcholine receptor antibody, and complement system, and mask antibody, MG standing for myasthenia gravis, and MG crisis, where patients require intubation or ventilatory support for breathing due to worsening of MG symptoms. Today's talk I have divided into 3 different parts. The first part, I will talk about MG disease mechanism and prevailing treatment targets. Second, I will talk about the most recently approved novel treatments in MG in little detail. And then I will talk about the potential treatments or upcoming treatments in MG. And of course, at the end, we will have time for some answering some questions from the audience. So talking about myasthenia gravis, a disease at the neuromuscular junction, this picture is showing a normal neuromuscular junction where at the normal nerve ending, acetylcholine chemical is released and it binds to acetylcholine receptor at the muscle membrane, and which triggers transmission of nerve impulse through the muscle membrane, resulting in muscle contraction. So that is a normal neuromuscular junction action. But in myasthenia gravis, what happens, you have antibodies to acetylcholine receptors, which takes place of the acetylcholine receptors, and the acetylcholine released from the nerve endings are not able to bind to the acetylcholine receptors. This causes reduced transmission of impulse or disruption of signal transmission from nerve to muscle, causing muscle weakness. To understand a little bit more about the autoimmune disease mechanism in myasthenia, I want to share a little bit about how in our body the immune system works. We have these B cells and the T cells, the immune cells in our body, which produces antibodies in response to antigen, like foreign body, any bacteria or virus. So that's how these B and T immune cells fights infection, for example. But unfortunately, in myasthenia gravis, our body's immune system starts attacking our own protein structures like acetylcholine receptor or MuSK component in our neuromuscular junction. That is the autoimmune portion of the myasthenia gravis. And this results in production of antibodies against acetylcholine receptors by the B cells. As you can see, the Y-shaped structures on the right side of the picture depicted by the red arrow. These antibodies are produced by the B cells, and these antibodies then causes activation of what we call complement system, and the antibodies along with the complement system attacks the neuromuscular junction, the acetylcholine receptors, and this causes disruption of the neuromuscular junction or destruction of the neuromuscular junction, resulting into muscle weakness. So this is a nutshell of the disease mechanism in myasthenia gravis. And we talk about now the drug targets where along this pathogenic pathway, which patients can benefit from MG or myasthenia. We are mostly familiar with pyridostigmine or mestinon, which causes increased availability of acetylcholine in the neuromuscular junction. This can take only part of the problem or solve only part of the problem, but this does not take care of body's immune response or antibody production. So most patients do not benefit just only with mestinon. Then comes the big players like medications like steroids or prednisone, which works on the body's immune system by almost shutting down the immune system so that there is less production of antibodies in myasthenia gravis. Other medications like cyclophosphamide also works in the same way. Other non-steroid agents like azathioprine, mycophenolate, or Celsat, cyclosporine, they all work on the T cell pathways, again, trying to shutting down the immune system and reduce production of immune antibodies in myasthenia gravis. On the other hand, treatment options like IVIG, intravenous immunoglobulin, or plasmapheresis, PLEX, they work by actually inactivating or removing these circulating antibodies from the circulation and tries to reduce MG symptoms. So there can be a potential change in the treatment target where we can target more specific pathways in disease mechanism in myasthenia gravis. In other words, instead of total shutdown or suppression of the immune system, we can find an acceptable level of countering the disease pathogenesis or disease pathway along with care monitoring of our immune system. So from immunosuppression to immunomodulation. And that's where the novel treatment targets in myasthenia gravis tries to highlight. So novel mechanism treatments for myasthenia gravis, immunomodulation than immunosuppression. They often tend to have quicker onset of action compared to the conventional non-steroid agents like Celsat or azathioprine. And overall, so far, the medicines we will talk about, which has been approved, the novel mechanisms, they tend to have a favorable side effect profile. To further understand in more detail about these drug targets for immunomodulation, when we talk about these novel mechanisms, we focus on the neuromuscular junction disease pathology again. So as we discussed, the B cells, the B immune cells in our body are primarily responsible for production of the antibodies. And one possible mechanism could be B cell depletion or B cell inhibition to reduce more production antibodies. Another target we talked about is the complement system, which along with the antibodies causes disruption of the neuromuscular junction, leading to muscle weakness. So one of the drug targets could be complement inhibition. And finally, the third pathway could be FcRn inhibition. We will talk about it in more detail. This kind of prevents a recycling of the antibodies in the system and tries to control symptoms. We will now talk about the approved novel treatments in myasthenia gravis in little details. The first one, which was approved, we talk about is eculizumab or Soliris. This was approved in 2017 for use for myasthenia gravis. As we discussed, complement plays an important pathway role in a disease mechanism. Soliris or eculizumab works as a complement inhibitor and thus protects the neuromuscular junction from the destructive effects of the antibody-mediated damage to neuromuscular junction. The trial was done for patients, or FDA approved the medication for patients who have refractory myasthenia. To further break down, refractory myasthenia are patients who have moderate to severe generalized acetylcholine receptor antibody positive myasthenia, and there should be evidence of inadequate benefit or unacceptable side effects from at least 2 immunosuppressive therapies. One of them could be prednisone and another non-steroid agent, for example, azathioprine or Cellcept. Or patients should have evidence of inadequate benefit or unacceptable side effects from one of the immunosuppressive therapies, and they are requiring maintenance treatment with plasmapheresis or plasma exchange or IVIG. So this is where the eculizumab or Soliris are targeted for. In terms of the trial data, patients were noted to have a rapid and sustained response. Most of the significant response was noted after 12 weeks of starting treatment. There was definitely less hospital admissions, MG exacerbations, and need for rescue treatment. Along with that, patients were noted to have also improved fatigue. Further following of the patients showed there was a decreased need for other immunosuppressive therapies at the same time. For example, when patients were started on the medications in the trial, 98% patients were on some sort of additional immunosuppressive therapies, and nearly 50% were able to decrease the dose of such immunosuppressive therapy. And also another 47 to 48% were actually able to decrease the dose of steroids, and nearly 11 to 12% patients were actually able to stop steroids. Additionally, since the drug has been approved in 2017, it has been used, and there has been some publication in the literature to show the real-world experience, and looks like the real-world data concurs in terms of Soliris or eculizumab's ability to reduce MG exacerbations and have better control of symptoms. In addition to that, it looks like there has been no difference, or this medication works across different ethnicities. This medication works even when patients are on other medications like chronic IVIG or rituximab. Dosing for Soliris, it's an IV medication. You need to go through an induction phase of weekly for 4 weeks, followed by a higher dose at week 5. And after that, you have to be on maintenance dosing every 2 weeks. Patients who are receiving plasmapheresis for MG rescue or as a maintenance therapy, they will need supplemental dosing when they are getting eculizumab. In general, the data supports a generally safe and well-tolerated medication. Most common side effects reported amongst patients are headache, common cold or upper respiratory tract infection, and musculoskeletal pain. Very important information to highlight: patients who are getting Soliris, before they can start Soliris, they should get meningococcal vaccination to prevent meningitis or CNS infection. This vaccination actually have two different types, main ACWI and main B. Both of them require at least 2 doses, and the second one, depending on the brand, may require 3 doses. But patients should get at least the first doses of both these vaccination 2 weeks before starting the medication. On rare occasions, we do start the medication with antibiotics, but preferable patients should get vaccinated before starting this medication. What is unknown about Soliris? There are still some population of patients among the acetylcholine antibody positive MG who did not or who do not respond to Soliris. We don't have a strong data or any study, actual trial looking at acetylcholine antibody negative myasthenia or MG associated with thymoma, who we are not included in the original trial. So we don't know if this medication works for these patients. There have been case reports reported in the literature, individual case reports, which mentions that there has been some benefit, but there is no randomized controlled clinical trials for acetylcholine antibody negative myasthenia. Finally, we don't know with complete response, once patients have been put on this medication, when should one start tapering the frequency of the dose or discontinue the dose? That information is not known to us. How long should we continue medication? That's kind of the case for most cases of myasthenia gravis. Regarding pregnancy and lactation data, only limited data available. No particular study has been done in patients with MG and pregnancy. There has been recently a single case report of successful pregnancy in myasthenia while the patient was on eculizumab. Eculizumab is also used in non-neurological conditions, and the data from those non-neurological conditions where eculizumab was used in pregnant patients, it did not show any difference in terms of congenital malformations or poor outcome or negative outcome of pregnancies as compared to general population. But particularly pertaining to MG, there is no study. Similarly, no or limited data is available regarding breastfeeding for patients who are on eculizumab. Next, we're going to talk about ravulizumab. That's one of the newest medications approved for myasthenia gravis. Very important to note, the mechanism is similar to eculizumab, but not exactly similar. One of the main differences, this is a long-acting complement inhibitor. This medication is approved for patients who have generalized acetylcholine antibody positive myasthenia, whose symptoms are not well controlled. And patients can be on any immunosuppression treatment or can be on pyridostigmine. So in the clinical trial, this was a little different compared to Soliris, where patients had to have refractory myasthenia. Here, patients could be immunosuppression or could be on mestinine only. Who were not included in the clinical trial were patients who has history of thymoma or thymic cancer or recurrence in the last 5 years, or history of a thymectomy within the last 1 year, patients who have received IVIG or PLEX in the last 4 weeks, and finally, patients who have received rituximab within the last 6 months. These patients were not included in the clinical trial. In terms of response, rapid and sustained response were noted in patients who received ravulizumab. Initial response could be seen within 1 week of starting treatment, and more than 50% cases response was noted within 4 weeks of treatment initiation, and treatment response was sustained through study duration of 26 weeks of the initial study. On extension of the clinical trial, it was noted improvements in activities of daily living, muscle strength, and quality of life were sustained through 60 weeks of ongoing treatment. Additionally, reduced events of clinical deterioration like MG crisis or need for rescue therapy or worsening of MG symptoms were also noted, suggesting beneficial role of the medication. And finally, there has been some post hoc analysis, meaning looking back at the data after the trial has been completed, that treatment if the treatment was started earlier in disease course, that may result in greater therapeutic benefit in patients. Dosing for Ultomiris is a little different. It's an IV dosing. Patients are supposed to get first loading dose, and followed by that, 2 weeks later, they're going to start a maintenance dose. And after that first maintenance dose, the maintenance dose should be continued every 8 weeks. Dosing is according to body weight, and supplemental dosing are needed if patients are getting IVIG or PLEX treatment. Safety trial data showed side effects were comparable to placebo. Again, this is a very recently approved medication. Not much time has passed to have more real-world data. Most frequent side effects reported were headache, diarrhea, upper respiratory tract infection like common cold. And since it's a complement inhibitor, mechanism is similar to use of Soliris. Patients who will be put on ravulizumab or Ultomiris, they need to get the meningococcal vaccination to prevent or reduce the risk of meningitis, as highlighted before. No pregnancy or breastfeeding data available for, or no dedicated studies actually has been done for patients to be on ravulizumab or Ultomiris. Of course, this comparison often comes patients who are on Soliris versus starting ravulizumab. One of the main difference is the maintenance therapy. Eculizumab or Soliris, you have to do treatment maintenance therapy every 2 weeks versus Ultomiris, the treatment is every 8 weeks. And another thing to highlight, patients who are getting ravulizumab, they need supplemental dosing of the medication if they're getting IVIG or PLEX along with the ravulizumab, versus supplemental dosing is needed for patients with eculizumab only for PLEX, not for IVIG. And finally, one of the newest medications is the efgartigimod or the Vyvgart. It's a first approval of a new class of medication, a novel mechanism approved in December 2021. It binds to the neonatal Fc receptor, which prevents IgG antibodies from recycling into blood circulation. And it thus reduces circulating IgG antibodies, including harmful MG or myasthenia gravis antibodies. So we'll take a closer look at the mechanism of action of this medication. In the picture, you can see this Y-shaped structure. These are the IgG antibodies. And as I mentioned before, these antibodies are basically weapons of our body, our immune system, to fight any infection, like bacterial or viral, and they're constantly circulating. And this red-colored structure called the FcRn, a neonatal Fc receptor, this acts as a protective gear for these IgG antibodies, which prevents their destruction. So FcRn helps recycling of these IgG antibodies within the circulation. But unfortunately, in myasthenia patients, there are these harmful IgG antibodies. FcRn also helps recycling of these IgG antibodies. So medications like Vyvgart actually targets this FcRn. On the left side of the picture, you see IgG antibodies, including harmful acetylcholine receptor antibodies, binding to FcRn. They can, when the antibodies who are bound, they are prevented from being destroyed. But when patients are put on medications like Vyvgart, they are actually binding to the FcRn receptors. So more IgG antibodies are available in the circulation, which can be destroyed. So this reduces the number of circulating both good IgG antibodies as well as harmful MG antibodies, and that helps in reduction of symptoms. This medication, Vyvgart, is approved for acetylcholine receptor antibody positive generalized MG. cannot be used for ocular or ocular predominant MG. Who were not included in the clinical trial, patients who have received rituximab or eculizumab in the last 6 months before the trial or enrollment, or patients has had thymectomy within the last 3 months, or had intravenous immunoglobulin or PLEX treatment within 1 month of the trial. Dosing for Vyvgart is a little bit different than the conventional treatment. So here dosing involves 1 hour IV infusion each week for 4 weeks, as you can see on the left side. So over 22 days, week 0 is the first infusion, and patients are supposed to get once a week infusion for 4 weeks. And such infusion consists of 1 treatment cycle, and then patients will be reevaluated by physicians. And depending on rate of symptoms, patients will get the second cycle, and so on. Looking at the response of treatment in patients with myasthenia to Vyvgart in the clinical trial, patients were started noticing improvement within 1 to 2 weeks of starting the medication. On the right side of the present slide, you see the red line shows the placebo or the no medication, versus the blue line shows patients who actually receive the medication. And as you see, the blue line goes down, or the MG-ADL score reduces, which means there is improvement of symptoms. And we start noticing improvement of symptoms in these patients within first week of infusion. Significant improvement was noted after week 4 and sustained for 4 or more weeks. 68% of patients noted to have improved ability with activities of daily living, and 65% with reduced muscle weakness. Symptoms started to come back at week 8 or to week 10, where week 0 was the first infusion. So I can see again in the picture, the symptoms started coming back after week 8, or for most of the patients who noted improvement. From the clinic trial, it was noted that average of 72 days were the duration between the first treatment cycle and the second treatment cycle, where patients were actually recurring the cycle, or patients were having return of symptoms. Regarding side effects, headaches and infection were reportedly the most common side effects in response to Vyvgart, and among the infections, respiratory tract and urinary tract infections were the most common. In addition, patients had infusion reaction, like allergic reaction, which can happen with other infusion medications, but no alarming red signals or red alarming side effects were noted or reported. Important to highlight who should not get Vyvgart. Patients who have actual serious infection, the infusion should be held, as Vyvgart helps or causes clearance of the IgG antibodies, including the good antibodies from our body. So if someone is having serious infection, this medication should be held. Along with that, allergic reaction medication should be discontinued. Important point to highlight, because of the mechanism of action of Vyvgart, patients who are on medications like rituximab, eculizumab, or revolizumab, or any other monoclonal antibodies, which we often refer to as biologicals, or if patients are getting IVIG, if they're also getting Vyvgart, the efficacy of these medications can be lowered. So it is important to discuss the medical history and go over the medication list when patients are trying to start Vyvgart medications, because the efficacy of these medications, the biologicals, can be lowered, and these medications patient can be on for other reasons, not necessarily myasthenia, and that needs to be addressed. Additionally, vaccination, since Vyvgart causes reduction of IgG antibodies, live attenuated or live vaccines are not recommended when patients are getting a Vyvgart. Looking at the extension of the original clinical trial, all patients received up to 3 years of treatment, and long-term effects, long-term safety and tolerability was noted, and consistent improvements were noted in both positive acetylcholine receptor positive and acetylcholine receptor negative myasthenia patients for up to 10 treatment cycles. Vyvgart is not approved for acetylcholine antibody negative myasthenia gravis, although in the clinical trial, both positive and negative patients were enrolled. For the negative patients, the number of study subjects who were recruited was very small. Improvement was noted among the negative patients, but because of the small study sample, it was deemed that additional studies and data are required. But overall, there has been also noted improvement in the acetylcholine antibody negative groups, including mask antibody positive patients. And the medication was also well tolerated. Unknown about Vyvgart, again, there is no human study data in terms of medications like Vyvgart during pregnancy, for its use during pregnancy, and during its use for lactation or breastfeeding. Another important question is often vaccine efficacy while on Vyvgart. So given these clinical trials, a big part of that was also done during the ongoing COVID pandemic. So there has been some data for this trial subjects or trial patients who also received the vaccination. And preliminary data shared suggested that treatment with Vyvgart did not affect immune response for COVID-19 vaccination. But this is a very preliminary data. Along with the IV treatment, which is approved for efgartigimod, there has been a subcutaneous trial for efgartigimod, which compared between IV and subcutaneous formulation. And the study results showed subcutaneous efgartigimod was similar or non-inferior in action when compared to IV formulation, and side effects and safety profile were similar. In addition to that, there is also recruitment for additional extension of the subcutaneous trial for ongoing monitoring of long-term safety and tolerability of subcutaneous efgartigimod. Another trial which is recruiting is the ADAPT Next trial, which is actually comparing continuous regimen either every 2 weeks or every 3 weeks as compared to the current treatment regimen, which is approved, where patients get 4 weekly infusions of 1 treatment cycle and reevaluation for the need for second treatment cycle. Because this treatment cycle-based regimen can be sometimes challenging for patients with monitoring of symptoms and can cause additional anxiety when the symptoms are coming back, as opposed to conventional scheduled treatment. So that's what this study is looking at. Additionally, there is some ongoing trials for juvenile myasthenia for use of Vyvgart. We'll talk briefly about one of the medications not necessarily approved for myasthenia, but often used off-label, which is rituximab. It's not necessarily a very new medication, but it is one of the biologicals. Mechanism of action rituximab works. We talked about B cell depletion, B cells, which are responsible for production of the autoantibodies. Unfortunately, there is not very great data in support for use of rituximab as a first-line treatment for acetylcholine antibody positive myasthenia. It definitely can be a second-line option in treatment failure or intolerance to conventional agents. On the other hand, As per guidelines, this is often sorted for as early initiation in patients with masked antibody positive myasthenia, who in general has limited treatment options. So as physicians, we often try to use rituximab when we see patients with masked antibody before going through multiple other treatments. One advantage for rituximab is the ease of administration or dosing. Patients can get one treatment cycle, which can contain like 2 doses, 2 weeks apart, or once a week for 4 weeks, and then no treatment for at least 6 months, and then repeat the cycle. So for some patients, it could be very convenient. So that's why it's often preferred, but definitely not always as the first line. Safety data is accumulated over several years, shows a favorable safety profile because rituximab is often used in other both neurological and non-neurological autoimmune disease. Finally, we talk about some of the non-approved treatments for MG. And few of them you should mention, one of them is zilucoplan, which is a complement inhibitor. And the advantage is it's subcutaneous, but it's a daily dosing. It has been looked at for patients with acetylcholine receptor antibody positive myasthenia. And the trial data shows or promises potential for rapid and consistent disease control and no expected major safety issues with this medication. Another medication will be rozanolixizumab. It's an FcRn inhibitor, which is the same as mechanism like efgartigimod or Vyvgart, but this is subcutaneous weekly. And the other thing is this has been looked into both for acetylcholine antibody positive and masked antibody positive MG. So far, as per the trial data shared in one of the recent conferences, the safety profile, it's a well-tolerated, acceptable safety profile. And MG-specific outcomes or improvement in symptoms were noted both for acetylcholine receptor antibody positive and masked antibody positive myasthenia. Another complement inhibitor, subcutaneous for antibody positive MG, acetylcholine receptor antibody positive. Other medications are in the different phase trials, like phase 3 ongoing trials, which is FcRn antibody mechanisms for these two medications. These two medications working on the B cell pathways, and important to note, these medications have recently been approved for other immune-mediated neurological conditions. And these medications are also being looked at both acetylcholine antibody positive and masked antibody positive MG. These medications have a different mechanism, and I wanted to highlight for some reason, as per my own research, this medication was put on hold for liver injury concern, but one of the big advantage was this patient it's oral daily. So we will see what turns out from these trials. Additionally, some of the medications used for juvenile myasthenia gravis are being under trial. And finally, some of the novel approaches I wanted to mention in the last 5 minutes of the presentation. One of them will be hematopoietic stem cell transplantation. To remind everybody, these are only for aggressive or refractory cases. These are aggressive invasive treatments, so usually not the first line in patients with MG. In this stem cell transplantation, basically all the harmful autoreactive T and B cells, immune cells, are removed from the body, and that allows some sort of immune resetting or rewiring within the system. And this can have a potential for lifelong sustained remission equivalent to a cure. And again, these are aggressive treatments. These are more reserved for refractory cases. There have been several case reports or few case reports in the literature with successful outcome. Finally, we need to mention about CAR T cell treatment or CAR T cell therapy. And in this treatment here, T cells are removed from one's blood cell, and they are genetically engineered to fight the abnormal T cells, and they are put back into one's body to fight those abnormal immune cells and kill them. This has been a revolutionary treatment approach in cancer world, and this has been actually being at the very initial stage being looked at for MuSK myasthenia gravis. Finally, at the conclusion, just to show a lot has been happening in the myasthenia gravis world in terms of emerging treatments. The medications highlighted in green are so far FDA approved, but as you can see, many of the medications are under trial in phase 3 or maybe in the pipeline over the next few years. And that's something very exciting for our patients with myasthenia. I wanted to share these particular slides for the information about the clinical trials. One of them will be Myasthenia Gravis Foundation of America. And if we go there, there are listed clinical trials, and you can go and click on this, each clinical trial they have listed and learn about them, who are recruiting, and get to learn in more detail. Or otherwise, you can directly go to the clinicaltrials.gov and you can put the name of the disease, Myasthenia gravis, and learn about different ongoing trials at different stages of development. I want to conclude here, and thank you so much for the patient hearing. And I will hand it over to Joan, and happy to answer any questions.
Thanks, Dr. Paul. That was great. It's fascinating how many different options are coming to market. I mean, over 15 are on that list. There are things that are infusions, I know, are taking a shorter amount of time. People are able to do some of these at home with that subcutaneous approach. Things are coming for MuSK and seronegative. It's just a very exciting time for MG.
Truly, truly.
Yeah. People shared questions in advance, so why don't I go through some of those? And then we've certainly got a handful that people have mentioned in the chat box too. These were some that were given to us ahead. Can you use Rituxan and Vyvgart at the same time?
That's an excellent question. So I shared in one of my slides patients who are on biologicals, which often we know by the name ending with MAB, MAB, monoclonal antibodies. These patients cannot take both Vyvgart and these biologicals together because the way Vyvgart or efgartigimod works, it will cause increased clearance of these medications from the system and will cause reduced efficacy of these medications. So patients cannot be taking both these medications at the same time.
Mm-hmm. Okay. Can you speak to new therapies and the impact and just concerns about MG patients often don't just have MG. They might have diabetes or hypertension or kidney issues or psoriasis. What happens with that?
Excellent question. So yes, definitely in general, we always be careful how the medications are metabolized in our system, by is it liver, by it kidney, and if someone has some sort of kidney problem or liver problem, or is it safe? So the medications, the 3 different medications which are newer relatively in the MG approved, none of them requires any adjustment for dosing in terms of any coexisting liver problem or kidney problem. None of them so far that we know about requires any adjustment. Having said that, if you mention about psoriasis, some of the medications used for conditions like psoriasis or other autoimmune conditions, patient might be again taking one of these biologicals. So if that is the case, then that has to be addressed because patient cannot take medications like Vyvgart and any of these biological monoclonal antibodies together. So when patients are starting Vyvgart, it's important to go over the medication list with their provider or physician.
Thanks. Okay. A person asks, are any of the new treatments effective for MuSK antibody MG?
That's a great question. Amongst the most new medications, even though it is not approved for MuSK positive MG, the data shows very limited, very few number of patients that patients can have benefit with medications like FcRn inhibitors. And as I was showing some of the medications which has not been approved, but the initial phase 3 trial data shows that the response to treatment, both for acetylcholine receptor antibody and the MuSK antibody positive MG, the medications particularly which are FcRn inhibitors can be beneficial. Unfortunately, medications which work through the complement pathways or complement inhibitors, they may not be useful, or they are usually not useful for MuSK positive myasthenia because of the disease mechanism. But definitely the other medications which work on the B cell pathways, I showed some of them, or the FcRn pathways, they can be definitely potentially beneficial in MuSK antibody positive myasthenia.
This was not a question, or actually I think it's a question that came in later. So if it's not approved for something like MuSK or seronegative MG, and what does the insurance say? And does that play a part in whether or not a person can actually have access to those meds? Is that something that you even get involved with?
I usually, it's a very tough battle for my patients. If it really gets down to that, I will try. But usually we always know, it's not going to be, most likely the chances, going to be getting approved is very low when the treatment is not actually approved for in this type of treatments or in this type of conditions.
Mm-hmm. Okay. And does it just come down to this didn't work and this didn't work, and things like the definition of refractory, where if someone doesn't respond to anything and this maybe is a last resort or a next resort? Is that how it could work?
Yeah, definitely. I mean, if that is what it boils down to as the last resort that we have to kind of take. But again, it depends on the mechanism of action. Particularly, we cannot use the complement inhibitors medications for the MuSK positive myasthenia particularly.
Okay. Are there any studies being done for seronegative MG? And what treatment options are there for seronegative other than mestinon and prednisone available?
Absolutely, very good. And as I was mentioning, one of the medications like Vyvgart, the data did not have enough patients, but it showed there is a potential response. Actually, this medication has been approved in Japan, both irrespective of the antibody status. So there is some compulsion, to be able to use these medications in seronegative myasthenia, which could include MuSK positive myasthenia. So I'm hopeful in the coming years we will have more patients and more data available to show that these medications like FcRn inhibitor, one of the novel mechanisms, can work in seronegative myasthenia.
Mm-hmm. The next question has to do with comparing Soliris and Ultomiris, but I think the question is basically how do all of these things stack up, and is one more effective than the other? The question is, do you believe Soliris or Ultomiris is more effective in the treatment of MG, and why?
It's a very good question. I don't think we can directly compare based on the clinical trial, because for Soliris, this medication was tried only for patients who had a refractory MG who has failed these two different types of treatment. Compared to that, Ultomiris, the trial patients did not have to have a refractory MG. So it's kind of very hard to compare. It's almost becoming between apples and oranges. But having said that, I kind of highlighted some of the differences between Ultomiris and Soliris. Ultomiris requires maintenance therapy every 8 weeks compared to Soliris, which is every 2 weeks. So that can be really life-changing for some patients. So that is something to consider. And also the other point, like if someone misses a dose of Soliris for something, the window is very narrow, right? You cannot go totally like 1 whole week without getting Soliris. But if a medication, if you're giving every 8 weeks, practically speaking, perhaps I'm not recommending, but it's possible to be still within the safe window if you have missed the medication for 3 to 4 days for a medication which is dosed every 8 weeks. So that's another practical thing possible, and of course the cost, every 8 weeks of going to infusion centers versus every 2 weeks. Having said that, I have had this conversation with my patients, and some patients said we actually like going to the infusion center every 2 weeks. So,
Yeah. Someone asked a similar question. I think you answered it, where is there she's on Soliris, can I take something that where I don't have to pay as much? And if you're having fewer infusions stretched out over more time, that can end up being that result, right?
Absolutely.
Yeah. Okay. Let's see. One person asks, when do you think we'll see Vyvgart in subcutaneous form? I know it's in FDA process.
Wow, yes, that's correct. I think it's just a few weeks ago in September, probably, that it has been submitted for review of the data. So, I mean, I don't, of course, know the exact timeline in general, like it can be 10 to 12 months before, we have green light for the approval, but everything seems very promising in terms of the data, which showed it is not any inferior compared to IV formulation.
Mm-hmm. Okay. Can you speak to the drugs that you've, this question is, what drug have you seen give the most benefit with the least side effects? It seems like the side effects of these new treatments, that they have a relatively good profile for that. Would you say that? Is that true?
Yes, so far from the data, what we have, it's very, looks like nothing very alarming in terms of the side effect profile, definitely. But I will definitely say that the newer the medications, lesser we know about the long-term side effects. Mm-hmm. So amongst these, I would say Soliris is the oldest, which has been used in the real world with the side effect profile so far. It's kind of similar to what has been noticed in the original clinical trials. So that kind of, we have to wait really for the other medications to have a really to have make sure monitor, because that can kind of change a lot of things. So we really have to monitor patients who are getting put on these medications to see if there's any other concerns or any side effect concerns. Mm-hmm. But overall, as you mentioned, yes, in general, they seem to have a safety profile. And the other thing is also the conventional medications like Imuran or Cellcept. We often have to do blood draws routinely. We don't have to do any of this with these medications.
Wow, that's amazing. One person, you talked a number of times about women's breastfeeding and pregnancy issues. One person asked, what are the potential side effects of these drugs on men's health, like fertility?
Great question. Unfortunately, I don't think any dedicated study has been done to look at closely about the changes these medications can cause in terms of fertility. Some of the medications actually looked into the animal data, but very limited. I would say we don't know.
Mm-hmm. Okay. I'm going on to questions that we got during the presentation. Is there a limit to the effectiveness of Ultomiris infusions?
One more time, is there any limit?
Yeah, is there any limit to how effective this therapy will be?
I don't see any obvious limit in the sense, overall, in terms of efficacy. One of the things is only, again, since the mechanism of action is complement mediated, complement inhibitor, so this drug is not approved or will not be beneficial with patients with positive myasthenia. But I don't see any obvious red flags or alarms with its use otherwise.
Okay. This question reminds me of someone who is newer to things. This person is on a regimen of 3 times daily with Imuran and pyridostigmine. I'm still very scared. Should I involve myself with some of the new drugs now? So
Excellent question.
He's had MG for a while. I know this person. Hi, Jerry.
Yeah, so it's very it's very hard to say like a one correct answer to this question. The myasthenia has a very different disease course. It depends on how long the patient has myasthenia. The initial 3 to 5 years is the most crucial part of myasthenia, and depending on how the symptoms are controlled or not controlled, if we think these patients' symptoms are not well controlled, I would say definitely considering one of these new medications, versus if medications have already been able to have the completely optimize the benefit, no symptoms, then I don't necessarily think that we should need to switch to a newer medication. I hope that answers.
Okay. Great. I think we have time for one more question, and then we're heading out. Okay. Did I understand you to say the patients continuing IVIG? Do patients continue IVIG while on Ultomiris? If IVIG is every 2 weeks and Ultomiris is every 8 weeks, would the treatments be done concurrently? I understood the two to be competing treatments.
Those two are not competing treatments, but like the medication can affect each other's efficacy. So if someone is taking IVIG or plasmapheresis, and they need to take additional doses of this medication, the Ultomiris, to make sure additional concentration is maintained in the circulation for the drug's maximum efficacy. It's just the mechanism how the medications work that patients will need supplemental dosing of the Ultomiris if they are concurrently taking IVIG or getting concurrent IVIG or plasmapheresis. And this is around the time of the infusions.
Okay. And I saw one more, and then we'll close off this. Just because this one interests me too. It has to do with are there any recommended treatments for ocular MG?
Unfortunately, we don't have any dedicated trial for ocular myasthenia gravis, and that can be sometimes ocular patients, myasthenia gravis patients can have really debilitating symptoms affecting their life very like adversely. But I don't think like any of these treatments I talked about are targeted towards specifically for ocular myasthenia gravis.
Yeah, that's something down the road, hopefully.
Yeah.
Yeah. Okay. Well, I think that's about all that we have time for today. And let's see. I'm just gonna. We can go to the thank you slide. Then I'll say my thank yous. So I want to thank you so much for sharing your expertise and your knowledge with us, Dr. Paul. Thanks to all of you. There's 62 people who have hung in with us on this very detailed but very interesting topic. So thank you to everyone who attended. If the folks who are on this webinar appreciated the information, please know that we would appreciate your support as well. And so that to show your support, you may want to go to our website, which is myastheniagravis.org. If you'd like more information about myasthenia gravis, that site is also a great place to learn more about the illness. And then we're just about ready to close. So if I can ask you not to close your screens as we close off, you'll see an evaluation survey that I hope that you'll be able to respond to. So thank you, everyone, and good night.